Hi, welcome back to your prescription for medication education. My name is Yenmi and I'm a pharmacist and I'm here to bring you quality information regarding medications. Today's video will be on mucosal and other dosage forms. I think this will be my last video on dosage formulations, so let's get started. Today's objectives are pretty straightforward. I'm going to be reviewing barriers to pulmonary drug absorption, discussing particle size and its relevance in pulmonary drugs, and covering dosage formulations used in pulmonary administration. The lungs can be divided into two main regions: the conductive airway region, which includes the nose, pharynx, trachea, bronchial tubes, and bronchioles. The respiratory region includes the respiratory bronchioles, alveolar ducts, and alveolar sacs. The lung consists of more than 300 million alveoli, which provide more than 70 meters squared of surface area for gas exchange. These alveoli are separated from capillaries by a thin interstitium with a thickness of about 0.5 to 1 micrometers. Because the lungs have such a large surface area and a thin respiratory membrane that drugs must diffuse across, this greatly increases drug absorption. There are multiple barriers to pulmonary drug absorption. The lung's mucociliary clearance system is the lung's primary defense mechanism and consists of the periciliary layer and the mucus layer. When drugs are inhaled, they can be trapped in the mucus layer and pushed outward towards the pharynx and expelled out of the lungs. Drug particles that are trapped in the mucus can have their dissolution, diffusion, and interactions with receptors hindered. Pulmonary surfactant is a lipoprotein complex that is secreted by alveolar cells to reduce surface tension, which allows the lungs to remain inflated. The lung surfactant also plays a role in the removal of drugs by promoting adhesion to mucosal cilia and uptake by macrophages and monocytes. Pulmonary macrophages and dendritic cells play a crucial role in eliminating foreign bodies. Endocytosis is one of the main ways that drug absorption of inhaled drugs is diminished, especially for particles ranging in size from 0.5 to 5 micrometers. Metabolic enzymes can also play a role in the absorption of drugs. In the lungs, some examples of enzymes include antitrypsin, protease, and trypsin. There are several advantages to pulmonary drug delivery. Medications that are delivered to the lungs avoid hepatic first pass effect. The lungs have a lower enzymatic activity when compared to the GI tract and the liver. Administration to the lungs achieves a high local therapeutic concentration and lowers the risk for systemic adverse effects. The lungs also have a large surface area, which is highly permeable, allowing for improved drug absorption, and a rapid onset of action can be achieved via this route. As far as disadvantages go, it's imperative that the patient must be able to use the device properly. Patients can also experience paradoxical bronchial spasms, and nebulizers are associated with infections that can occur if the nebulizer reservoirs aren't cleaned properly. The drug's particle size heavily influences where the drug accumulates in the respiratory tract after oral inhalation. The main aerodynamic deposition mechanisms for inhaled drugs are inertial impaction, sedimentation, and diffusion. Inertial impaction occurs when inhaled particles cannot follow the sudden directional changes in airflow in the respiratory tract that occur at airway bifurcations and bends. Particles greater than 5 micrometers in diameter will collide with the airway walls and deposit in the upper respiratory tract, such as the oral pharynx and conducting airways, instead of the lower respiratory tract. Sedimentation occurs to particles that measure from 0.5 micrometers to 5 micrometers. These particles settle out of the airstream under the influence of gravity onto the airway walls or alveolar surface. Diffusion is the mechanism by which very small particles, less than 0.5 micrometers, move randomly due to the constant collision with gas molecules, which leads to unpredictable deposition in the alveolar region, which is why a large fraction of these particles are exhaled. The ideal particle size should be about 3 micrometers because more than 50% of these particles deposit in the alveolar region. The ideal inhalation device should be easy to use, especially for children and the elderly, and when needed for acute attacks. The device should provide feedback on proper use to ensure proper patient handling. Ideally, these devices should display some sort of dose counter to indicate how many uses remain in the device. They should be portable and inconspicuous to provide convenience to the patient. The device's mouthpiece should be easy to clean to maintain a hygienic environment. And lastly, the device should provide accurate and uniform doses with each use. The pressurized metered dose inhaler is a handheld delivery device that utilizes a pressurized propellant to deliver medication. Between 20 to 100 microliters of aerosol is delivered with each actuation. The basic components of the pressurized metered dose inhaler include the canister, propellant, drug, metering valve, and the actuator. The patient must have the ability to slowly and deeply breathe in while simultaneously pushing in the canister. For children and adults who cannot coordinate the two steps, then a spacer or a valve holding chamber is recommended. Children under the age of 3 should be provided with a spacer and a face mask combination. A valve holding chamber is a type of spacer, but it has a one-way valve at the mouthpiece end, which prevents the patient from exhaling into the tube. There are two types of pressurized metered dose inhalers, which are the conventional and the liquid metered dose inhaler, also referred to as a soft mist inhaler. The conventional pressurized metered dose inhaler is a press and breathe design device. The canister is depressed into the actuator, which causes the drug propellant liquid mixture to vaporize into an aerosol. The propellant that is used in devices now is hydrofluoroalkane. Advantages include its portability, making it convenient to use when needed. They have multiple uses and deliver pre-measured doses, and their design makes them difficult to contaminate. One of the major disadvantages is the hand-breath coordination required for proper administration of the medication. High oral pharyngeal deposition occurs on use, and there is a chance that the patient can have a reaction to the propellant, which typically makes up about 80% of the mixture in the canister. Pressurized metered dose inhalers also require priming before use, so you must ensure the patient is advised to shake the device well. Soft mist inhalers are propellant-free inhalers that produce a fine, slow-moving mist. The mist is generated via the transfer of mechanical energy utilizing a tension spring, which when activated forces the liquid through the mouthpiece. They typically deliver between 10 to 30 microliters per dose, and the actual dose delivered is usually lower when compared to dry powder inhalers and delivered doses in the microgram per dose range. As with most dosage forms, there are several excipients added to perform specific functions. Buffers help maintain pH stability of the solution and minimize irritation to the respiratory tract. Tonicity agents like sodium chloride help adjust osmolality to be isotonic to mimic physiological airway fluids, reducing irritation to the patient. Surfactants like polysorbate 80 reduce surface tensions, creating uniform aerosol droplets. Preservatives such as benzalkonium chloride are added to inhibit microbial growth and extend shelf life, and solvents such as ethanol reduce droplet size and improve drug solubility. Similar to pressurized metered dose inhalers, soft mist inhalers also require priming, but there is no need to shake them as they do not have propellants. Dry powder inhalers are small portable devices which are propellant-free inhalers containing micronized powder, a mouthpiece, and a dose measuring system. They were developed as an alternative to pressurized metered dose inhalers to minimize the ozone-depleting effects of chlorofluorocarbons and greenhouse gases such as hydrofluoroalkanes. They are patient-friendly because proper coordination is not needed. Common excipients that are used in this formulation include polyols such as mannitol, which is a crystalline carrier that can be used to create crystalline drug excipient complex, which stabilizes the drug and improves powder flow. Sugars such as lactose, sucrose are used in formulations to create solid particles that increase the stability and improve uniformity. Surfactants such as polysorbate 80 reduce interparticle cohesion, reducing surface tension and improving aerosolization. Amino acids like leucine act as a pH stabilizer, which enhances aerodynamic performance, which aids in better and deeper lung deposition. Lactose is the most frequently used excipient in dry powder inhalers and is present in more than 75% of them. As pharmacists and healthcare providers, we should be cautious of patients who have cow's milk protein allergies. Pharmaceutical grade lactose is derived from cow's milk so it is purified, but it can contain trace amounts of milk proteins. The amount of milk proteins may be relevant for some patients, but there have been reports of dry powder inhalers being contaminated with milk proteins, leading to allergic reactions, mostly in children. The FDA approved dry powder inhaler product labels to include a contraindication for the use in patients with cow's milk protein allergy. There are several dry powder inhaler systems, but the carrier-based system is the most widely used formulation. These systems consist of the active pharmaceutical ingredient, which is adhered to a carrier such as lactose to form a particle size ranging from 100 to 150 micrometers, which can be stored in a capsule. A deep and forceful inspiration through the device is required to deagglomerate the powder into the desired particles with a diameter of 1 to 5 micrometers. Single-unit dry powder inhalers can be disposable or reusable, and the dose is inside of an individual capsule. The capsule is then placed inside the inhaler, which is punctured, and its contents are inhaled. Multi-unit dose dry powder inhalers contain metered, sealed, and packaged doses on a disc or in a blister pack. These offer the advantage of ensuring an accurate dose is given, unaffected by the patient's handling. Multi-dose reservoir dry powder inhalers include a reservoir where the powder is stored loosely in bulk, allowing a higher capacity of doses, up to 200 doses per device. These often have a rotating mechanism where the base of the device is twisted to use, or a sliding lever or cover, which is slid from one side to the other. Active dry powder inhalers possess a built-in energy source to aerosolize the powder. Examples include compressed air, electrical vibration, or heat as a possible energy source. Passive dry powder inhalers are the most common dispersion mechanisms that are used. They require the patients to inhale with enough force to deaggregate the powder. The patient should generate a minimum of at least 30 liters per minute inspiratory flow rate, but ideally for superior delivery, the range should be between 60 to 90 liters per minute. Small volume nebulizers are aerosol generators that convert liquid into aerosol. They are often prescribed to children and the elderly. There are several types and subtypes of nebulizers, such as the pneumatic jet nebulizer, electronic nebulizer, and ultrasonic nebulizer. I'll cover the T-piece jet nebulizer with a reservoir tube because it's the least expensive and the most used type in hospitals and clinics. This nebulizer will release aerosol continuously regardless of the patient's breathing pattern, and it's estimated that only about 10 to 20% of the aerosol is actually inhaled. The word jet comes from the jet of pressurized gas that is forced through a narrow orifice. The pressurized gas leaves the orifice and mixes with the liquid medication to form a mist. They require between 2 to 10 liters per minute of pressurized gas, which is usually compressed air to function. The use of a mouthpiece is preferred over a mask because the mask increases the aerosol being diverted towards the face and the eyes. Some advantages of nebulizers include the ability to mix compatible medications, the decreased need for coordination for the patient, the amount of medication that can be modified by adjusting the amount deposited into the nebulizer, and they also don't require inspiratory pauses, which is recommended in the use of most metered-dose inhalers and dry powder inhalers. Some disadvantages include the time required to complete the treatment, which can range from 5 to 25 minutes. The need for a power source, which is more restrictive for patients. The need to clean the device appropriately to prevent contamination and infection risks. And the variability that can occur from various models and brands available on the market. Nebulizers used in crying children will greatly diminish how much medication actually enters the respiratory system. Crying while performing nebulization can cause the medication to be deposited mostly in the upper airways and the pharynx. Jet nebulizers should be cleaned after each use. This should include the nebulizer cup and the mouthpiece, and the patient can use distilled water. And for disinfection, the patient should refer to the manufacturer's recommendation, but common methods include the use of 70% isopropyl alcohol, and air drying is essential to prevent bacterial growth. And that was your dose for medication education. I hope you enjoyed today's video. And today being September 25th, happy World Pharmacist Day. I hope you guys are enjoying my videos. And like I said, this is going to wrap up the dosage form videos. I'm ready to move on to something else. If somebody out there in my audience has a recommendation, please let me know. I'm totally for it. Anyways, thank you for watching. Please like and subscribe, share my videos. Have a great day.